For those who just joined, we are giving a minute to those who are joining so that we can start. Thank you so much for joining. I think we can start. Good afternoon, good morning. Hello, everyone, depending on where you are, different time zones. Welcome to the Global Men and HIV Technical Working Group MENT webinar series. This is webinar series or episode number 10, meaning we've done 9 of them already so far. So basic housekeeping, you are going to receive the slides for this webinar. After the webinar, you also receive the recording. As we have always done, maybe for those who are joining us for the first time in this series of webinars, let us engage. Let's share stuff through our chat box. We also have a Q&A dedicated box that we can ask specific questions to our panelists. We've got a wonderful panel here who will be ready to respond to your questions. So let's separate the questions from the general chats that we will be having. Let's engage in the general chat. Let's share information in the general chat. Let's engage the presentations and let's ask specific questions in the Q&A chat box so that it's easy for us to track those questions. Every time we do these our webinars, we realize that there are those who are joining us for the first time. Today, we've got this wonderful panel. It's going to be a 1-hour session with 2 presentations, followed by a Q&A session. We thought we should focus on breaking barriers and bridging gaps for today's webinar, where we are going to be addressing gender and age disparities in HIV services for men. We have got Gift Dlamini from Eswatini, formerly Swaziland, and also we've got Andrea Breeze, who is from the UK, and they're going to share us their wonderful work they're doing pertaining to men and HIV. Those who have not joined this webinar series, or they heard about MENT for the first time, or they got forwarded this meeting invite by a colleague or by those whom we are working with, MENT was launched March 2021. To bring together a group of people, partners, ministries, everyone who is interested in this topic to share about the work that we are doing. Also, MENT, the group, it helps to coordinate these activities to improve outcomes for men, help to support any development of operational guidance to improve services for men, including identifying interventions and reviewing technical documents. Also, we're here to help identify, collect, and share best practice and case examples. And this webinar series is one of those platforms which we created to make sure that we have a platform to share. Also, dissemination of guidance, briefs, and lessons learned, and support scale-up effective interventions, including providing technical assistance on work related to men and HIV. Just to highlight to you some few data slides presented at IS recently by one of the co-chairs who is also on this call here. This slide is just indicating that men are still lagging. These are the new estimates that UNAIDS released just this July at the AIDS conference in Munich. You can see across the cascade people who know their status, people who are on treatment, and also those who are virally suppressed living with HIV. When you compare men and women, you can see the gap that is there, approximately 10% gap throughout the cascade, just highlighting that we still have a challenge as far as men are concerned. When you look at that gap across the different regions, and then you calculate the difference across the cascade of those 3 indicators, for the three regions, and then you plot that difference. This is what is plotted on this chart here. Approximately around 10%, even higher in other regions. We can see where that challenge is across Asia Pacific, Eastern and Southern Africa, Eastern Europe and Central Asia, West and Central Africa. And we can see that the challenge is not equal across the different regions. In other regions like MENA, Middle East, and North Africa, we can see that it's the other way around, where men are doing better across the cascade compared to women. These were just data slides to highlight that there is work to be done, and interest to continue this kind of work where we can continue to discuss this topic. When you convert those percentages into absolute numbers, just for the first of those indicators, we can see here across the regions, the absolute number of men who don't know their status by region, or undiagnosed men by region. We can see those are big numbers when you translate those percentages, which might appear small, but they're big numbers when you convert it to absolute numbers. This is just to highlight the magnitude of this challenge around men and HIV. So today we have got that wonderful panel I indicated earlier on, Gift Dlamini from Eswatini, as well as Andrea Breeze from UK. They are going to share. Gift is going to discuss men and HIV dialogues, wonderful work they're doing in Eswatini. Also, Andrea Breeze is going to share with us work on phylogenetic analysis or HIV transmission dynamics, looking at the increasing role of men in African populations with high antiretroviral therapy coverage, just highlighting also the need to put more effort around how we're addressing the HIV gap among men. This will be followed by a discussion facilitated by one of the co-chairs of the men group, Afsa Muhammad, who is from ILO, and then closing remarks by also one of the co-chairs of the group, Wole Amian from WHO. Without further ado, I want to introduce Gift Dlamini. The floor is yours to share your work from Eswatini. Over to you.
All right. Thank you so much, Lysias, for the introduction. Good morning and good afternoon, colleagues all over the world. Maybe, Lysias, if you can allow me to start sharing.
Yes, you can share. You should be able to. Are you having any challenge from your side? Happy to. Gift, any challenge?
Hi, Lysias.
Yeah, we can hear you, but we can't see the slides. Can you try to share again from your side? Yeah.
Can you hear them now?
Yes, perfect. We can see it now.
All right. Thank you so much. Apologies for that. So, as I mentioned, my name is Gift Dlamini. I'm from Kwaka Indodza, from Eswatini, formerly known as Swaziland. So, I'll be sharing with you dialogues with men in specific communities. So, my the project and also the research, and then our methods and the result. In terms of our results, they will include our social demographic characteristics, health self-assessment, gender equitable measure scale, and dialogue content analysis. And then in terms of the organization, we're a male mentoring organization working with men. We're active over 32 constituencies in the country. Also, we implement through community offices. We call it community chapters. Vision is a healthy, resilient, and gender equally Eswatini, guided by positive and informed men and boys. And then the mission is to mentor men and boys as allies of gender equality, social justice, and well-being. And then for the objectives of the Lisango Letembilo, we were to conduct dialogues with men from different contexts across Eswatini to listen to their experiences in accessing health services, also collect and analyze qualitative and quantitative data on men's experience in order to inform future programming. Also, we were to host a leadership retreat with decision makers and also host a men and HIV forum within Eswatini. And then in terms of the research, so it was also, the background was around the men's reluctance to access health services due to facility and service provider barriers. And then also fewer men living with HIV, 92% are aware of their status than women living with HIV. And then also there's reluctance to know the HIV status due to systemic issues and gender norms. So the objective was to establish the reasons for infrequent visits to health facilities by men, to identify facility-based barriers and challenges which prevent them from uptake of services, and also to determine priority facility-based elements that are conducive for men. And then in terms of the method, this research was approved by the EHRP. So and also we used survey attitudes toward HIV, health services uptake, and gender equality conducted. And also there were guided self-assessment and questionnaire. It was also in both Swati and English. And then also we had the discussion with men with 25 groups and a total of 825 boys and men from rural and peri-urban areas participated in this research. And then this is a map of Eswatini. I won't go through it. It shows the different sites that we implemented the dialogues in. And then also this, the research groups and locations, it was spread across the country. And then as you can see, the target groups, we have different a demographic of target groups from community men to older men, youth, and also those who are working. We also target key population. We also target asylum seekers. So it was a mix of different populations of men. In terms of the research, the method, the self-guided administered questionnaires, and also we had a group discussion, the community dialogues where we collected the qualitative research. In terms of the results, we have briefly the social demographics. You can see the chart, but I will concentrate more on the summaries that the majorities were those who are 25 to 25 years old, and also 40% were unemployed, and also most were in relationship with unmarried partners. And then we also did a track on religion, where we seen that we had 6 religions that were presented during the dialogues. In terms of research results on health risk self-assessment, so first, this STI infection was at 27%. So, and also in terms of half of them did not visit health facilities when they had STIs amongst those men who participated in these dialogues. And also 50% of them had sex without a condom with someone they didn't, with someone whose history they don't know. And then also when engaging with them, we also noted that men generally, they are aware of their own HIV risk. And then also continuing with the HIV risk assessment, we noted that 34% of them are engaged in multiple sexual partners. So it is still common, which is also a risk in terms of HIV prevention and also the spread of HIV and STIs. So also we noted that there is inconsistent use of condoms, which also with someone paying for sex, and also which is 16%. And also there is some men, we noted that during the dialogues when they were asked if they ever tested for HIV, 25% of them reported that they never tested for HIV. And then also 44% consider themselves as medium risk and 55% at high risk of contracting HIV. So the question to also ensuring that we do understand that the question on STIs were also used as a proxy for HIV status. And then also the results were concerning in terms of maintaining the 95-95 target that we have achieved as a country. And then also in terms of continuing with the health risk assessment, we noted that more adolescent boys and young men, they reported consistent condom use, though it starts to decrease steadily with age as they grow up. And also more young adults and middle-aged men have risky sexual encounters. And also as expected, condom use among older men was decreasing, so it is lower compared to the adolescent boys and young men. Also, the middle-aged men and young adults are very much aware of their personal risk as reported earlier. Also, these groups also have more men who have sex without a condom with unknown person. Also, the older the men, the more they believe women should be sexually submissive, as you can see on the charts on my right. And then in terms of the gender equitable men scale, most men believe that to be a man, they need to be tough. You see the 59+13, while over half believe a wife has to respect and accept what what the husband is saying, which is also an issue in terms of negotiating for sex, also the issue around consent, also the issue around the negotiating of safer sex in terms of condom usage, and also for other products such as PrEP. And also most men felt that they should always be ready for sex, and women cannot refuse sex with their husband. And again, when we look at these results in terms of men being ready for sex, it also speaks to the issues of negotiating sex with your partner and also negotiating a condom. In terms of also the lobola payment does not mean wife ownership, which is also a positive. Avoiding pregnancy is a responsibility of both men and women. It's also seen as possible, as also positive in terms of the 61 and 16%. And also the husband should not beat their wives. So this means our gender work and also GBV prevention work, it is really impacting in the community, though these results are still not at the level where we want to see in terms of achieving gender equality. And then also the father participation is important in child's upbringing. Also, we are seeing positive results considering our patriarchal society and also lack of parent or male involvement in child caregiving in our context. And then also the home care role and diaper change still considered women roles, and also the traditional role for men as women decision makers. They do split as the men, they are seen as responsible for making those roles at home. And then going down to, in terms of men had higher gender equality score above 30 or 45 from the 15 questions. And then also moving quickly, the adolescent boys believe a man has to be tough, this also age, and also men, they still believe in more rigid domestic gender roles. And then more than half of the men agreed that men are always ready for sex. And also the adolescent boys and young men had the highest believers, and older men had were the lowest believers. I think this also goes to the issues of culture, the upbringing, and also the stereotypes around the expectations around men in our context. And then also in terms of the dialogue content, when we now were collecting the findings or the submissions from the men. So all the men, they knew someone living with HIV in their communities, and also they knew through disclosure, some through rumors, and also some calls from facility, and also the frequent care, so the frequent visits to facilities. And also we've seen that families support people living with HIV on medication adherence and also financially, since the issue of accessing services from facilities can be a barrier in terms of those who don't have financial support. And also we noted that some families, they still discriminate, reject, and also develops toxic relationship around those who have contracted HIV. And then also for PLHIV, acceptance is still difficult. There's still a fear of discrimination and also a fear of rejection. In terms of the main experience in the facilities, there are negative experiences and also positive experiences that were reported. There is the issue of frustration of long queues, also long wait without no attention, and also where services are not provided in a supermarket. Report of harassment when one is reporting a recurring HIV or reinfection. So in some of the facilities in the rural areas, you find that relatives are working in these facilities. There's also the issue of duty of care around the negligence, rudeness, and shouting, and isolation, only men feeling like neglected, being there for more than 5 hours. And then I will jump to the positive since the presentation is going to be shared, but there's the issue maybe of embarrassment. Also, this embarrassment has to go with even after discussing with the female staff now, having to show or expose your private parts. So it's felt as an embarrassment to most men. And then the positive experiences at male health facilities, which is what we are advocating for. They reported friendly health service providers, also the woman gently, and also the woman gently service providers, and also the environment when men are in the health in these male service centers, and also it's welcoming, and also depending on their attitude and moods and our moods as men attending the health facilities. Then in terms of the expectations, professional duty of care at OPD and registry, also the first come first serve based, as some of these men are rushing to work even after accessing the services, providing health services after work and also after lunch, since some services you find that men are then required to come back after or the following day. So they also mentioned that senior male staff who understand men issues when men come to the facilities, they want to be also understand, to be engaged by those who they believe they have experience in terms of male staff. And then why male-friendly clinics? Because we wanted to know why them then. To access male-friendly services, also corners around the clock, particularly after work, men want to have up to access services after they complete or their daily duties or they knock off work. Also to attract men so that they are able to seek health services, for men to open up about their health, particularly the STIs, which they feel like they are being embarrassed when exposing them to female nurses. Also to avoid long queues, to allow men to freely discuss issues that affect them, for privacy and confidentiality, since they also mentioned on the previous slide the frustration that comes with being a lonely man in a queue full of women. Also, they do want to be attended to by male staff, if possible, and also to allow equal access to health services. And also the barriers, as they were mentioned earlier, around the service providers. This is a summary on also the service delivery issues, access to health services challenges, which speaks to cost, transport services, and then also the gender norms. Men need to be tough, men need to be ready for sex. It also affects them. It also acts as a barrier in terms of now having them to access services, as they also, with them being expected to be tough or perceive themselves as tough, they then report late for health services. There's also the cultural and religious belief where men doesn't want to be injected, or some men, they try the traditional stuff before they enroll for the clinical service provision. And then the personal, the fear of injection, fear of medication, and the fear of unknown, and also the dependent on particular results or the partner's result, and inpatient to take ARV daily. And then these were some of the quotes from men who participated in this research, so which I think, for the interest of time, I won't go through them. Colleagues will go through them as they go through the slides themselves. In terms of the conclusion, so as the men are generally aware of their HIV and own risk to HIV, particularly those related to their lifestyle choices. Also, men do engage in risky sexual behaviors, which also requires us to do more male engagement, and also service provision, and also some of the gender norms on masculinity. They directly influence HIV transmission on gender-based violence. And then the modern health facilities sparingly used, mixed of modern and traditional services are used by men. And then men felt they are stronger and do not need much health services as men. And then in terms of the expectation, in conclusion, they do advocate for separate male health facilities, male healthcare workers, flexible time and male health services, and then a professional duty of care. Thank you so much, colleagues. This brings me to the end of my presentation. We'll take this opportunity to also appreciate the colleagues that contributed to this research, which included our Dr. Mary Mhazo, who was the lead researcher, Tom Chetiat, Gifty Lamini, Sibusisiwe Kamete, Simanga Mbusweni, Nosisa Ngwenyama, and Simpiwe Mamba. And also we had our photographer who was helping us during the dialogues, who's Chandombuli. Thank you so much. Over.
Thank you so much, Gift. Yes, a lot of data presented here. I already see some questions starting to come in concerning this presentation. Really great to see, especially work touching the gender-related aspects of engaging men in addressing the men gap in HIV and related services. You may want to check the Q&A function because I see already questions are coming in. I would like us to go straight because we want to be able to have good time or enough time for the Q&A session. Let's go straight to the next session, which I'm really also excited about. Over to you, Andrea, for the next presentation. And colleagues, feel free to use the chat function. Feel free to use the Q&A function to ask questions. Let's engage. If you've got any related information or links you want to share in the chat box as we discuss, feel free to post in the general chat function. Over to you, Andrea.
Hello, everyone. Can you see the slides?
Yes.
Okay, perfect. So yeah, a good morning, afternoon, evening, everyone. I am Andrea. I am a PhD student at Imperial College, London, and here I'm part of the StatML Center for Doctoral Training. Today, I would like to present my project examining the demographic profiles of HIV viremia. The focus of this talk won't necessarily be on how to best reach and engage men, but rather understand why it's becoming more and more important to focus on this problem. The work I'm presenting here was done in collaboration with my supervisors, Oliver Ratman at Imperial and Kate Grabowski at Johns Hopkins. And before I start, I think it's always important to thank the participants and staff that are involved with the study, which in this case is the Rakai Community Cohort study, which always provides invaluable data for this and many other analyses. The motivations of this study fall into the wider context of understanding the drivers of HIV incidence. This is crucial because incidence reductions are needed to achieve epidemic control by 2030. And the previous studies have shown that increasing the rates of viral suppression among people living with HIV reduces the risk of HIV transmission. The 95, 95, 95 UNAIDS targets provide metrics to assess the extent of this viral suppression across different population subgroups of people that live with HIV. And in practice, these targets are also used to direct interventions to the groups that are furthest from achieving this. However, these metrics do not really account for the sizes of the underlying populations and of the populations living with HIV, which are crucial to determine the contributions of each population subgroup to the overall burden of HIV or the overall burden of viremia. This talk focuses on data that comes from the Rakai Community Cohort study, which is an open population-based community HIV surveillance cohort in southern Uganda. Here, we focus on 4 survey rounds of the study that span from 2013 to 2019. How the study works is basically that there's these communities are visited one after the other, and there's censuses that go on to understand the underlying sizes of the population. People are then invited to come for free testing that includes HIV testing. And then people that participate are asked to fill some questionnaire. We typically divide the communities in this region in 2 types. There is fishing communities and inland communities. And there's many reasons why we prefer to separate this. So one of them is, for example, the main economic activity is different, but also people that live there are different in the sense that, for example, the population pyramids are different. In the case of fishing communities, there's lots of people that are of working age, while in inland community, population structures are more similar to the typical population structures in Eastern and Southern Africa. Further, due to fishing communities also have higher HIV prevalence, which also means they received priority interventions. And for instance, the earlier implementation of universal test and treat, which started 3 years prior to the national rollout in 2016. Here, the goal of the analysis are to analyze the data from the tests, the HIV tests, and the tests for unsuppressed viremia, here defined as having more than 1,000 copies per ml. And the endpoint is the estimation of the prevalences of HIV and viremia, as well as the characterization of the age and gender profiles for the burdens of HIV and of viremia. This figure here gives a bit more insights into the structures of the underlying populations and of the participation rates in the study. In the top half, we have data for round 16, and in the bottom half for round 19, and that is years 2015 and years 2019. The white bars represent the number of census individuals, so the true underlying population, while the colored bars represent the number of participants. We can see again that the population pyramids for fishing communities that are shown on the left have a higher proportion of individuals aged 25 to 35, while the population pyramids for inland communities have populations that decrease with age. And we can see also that the participation rates tend to be higher in women and in inland communities. To summarize the study numbers, we have this slide. We have about 38,000 individuals that participated to at least one of the survey rounds. And of these participants, about 18%, so almost 1/5, tested positive at least one time. And for almost every visit of an individual with HIV, viral loads were measured. So the viral load data we have is very good. And so what we did with this data is that first we estimated the prevalences of HIV and of viremia within each age and gender group. And we have some models that account for the uncertainty due to the missing, to the people that did not participate in the study. Then, to account for the underlying population sizes, we additionally estimated the age and gender burden profiles of the population living with HIV and viremia. And in summary, what this means is that these burden profiles describe the contributions of each population subgroup to the total number of people with HIV or viremia. And so maybe the best way to describe this is with an example or with a figure that compares the metrics. First, on the right, we have a table that reports the changes in the overall HIV prevalence by location in facets, sex in column, and over time in the rows, while the figure on the left only focuses on the last of the rounds in 2019 and shows the prevalences calculated within each age group. Again, on the left, we report the results for women, and on the right, the results for men. As typically the case in Eastern Africa, we see that prevalence is higher in women, and for example, it is increasing with age. However, what we don't see in this figure is the population sizes. And therefore, when we compute the contributions of each age and gender group, that is here shown in the black line, we notice that although prevalence is highest in individuals that are aged over 40, there are more people living with HIV that are aged 25 to 40. And so to make the same argument, we can make a similar argument, but relating the rates for unsuppressed viremia. Again, we have a table on the right that reports the overall prevalences in the same format as before. And again, the figure focuses on the 2019 data. The table reveals that the rates of unsuppressed viremia are lower in priority targeted fishing communities and also in women. And the plot represents the rates of unsuppressed viremia calculated within each age group, and they're shown in the red bars. And we also show as a dotted line the 14% rate implied by the 95-95 targets. So basically, if the bars are over, this means that the age group did not attain the target. And so what we can see is that across all communities and genders, individuals aged 25 or less are not reaching the UNAIDS targets. But again, when we do something similar as before and we overlay the age and gender profiles for the burden of viremia, again, when we overlay the age and gender profiles, the lessons differ. So in other words, the green bars here represent the proportion of all people with viremia that are of a certain gender and age. And the plot shows that there are fewer individuals exhibiting viremia that are aged 25 or less, as compared to those that are aged 25 to 40. Further, men also contribute to more than 50% of the burden of viremia. And this proportion is even larger in fishing communities, where men represent more than half of the resident population. One other thing that is important to note, even though it's not explicitly shown in the plot, is that fishing communities still have a higher population viral load than inland communities, meaning that the fraction of all individuals, so including also HIV negatives, who have unsuppressed viremia is larger than in inland communities. And so to conclude, I would like to end with the take-home messages. So what I would like you to learn about this presentation, which can be classified based on the level at which you want to make a conclusion. So regarding the priority populations, we know that although suppression rates among people living with HIV are lowest in fishing communities, there are more individuals there with unsuppressed viremia as a proportion of the entire population as compared to inland communities. Regarding the gender differences, following the scale-up of universal test and treat, by 2019, there were more men with unsuppressed viremia than women with unsuppressed viremia. And finally, regarding age differences, although suppression rates are lowest among youngest individuals, there are more individuals aged 25 to 35 than individuals aged 15 to 24 with unsuppressed viremia. So the overall conclusion is that for the context of HIV prevention, the UNAIDS targets should be considered together with alternative metrics, such as the burden profiles for HIV and viremia that I presented today. Before concluding, I would like to thank my mentors, Oliver Ratman and Kate Grabowski specifically, but also all the other collaborators that helped us in the project, the funders, and again, the people involved in the study. If you're curious about the preprint and want to learn more about how the results were obtained, there is a link to the preprint. And there's also other work, for example, including phylogenetic analysis that Lichas mentioned before. So thank you for listening, and it was very nice to talk to you.
Thank you so much, Andrea. This is an excellent presentation, rich in data, always something new coming from this group for this work that we're doing on this platform of MENT. I see already some questions that are coming in the Q&A function, and also people are posting in the chat function. I would like to hand over to Afsa from ILO, who is going to facilitate the Q&A session. And colleagues, feel free to raise your hand and we'll unmute you as we go through this session. So over to you, Afsa. And thanks to our two presenters. Thank you so much. Over.
Thank you, Lysias, and thank you very much to Gift and Andrea for your excellent presentations. I think both have provided us some very interesting insights backed by data. And I see some questions already in the questions and answers. Let me pick up the first question for Gift. And Gift, I hope you have seen it in the chat box. So you may like to take up these questions. You want me to read out to them. And I also invite other participants to please write your questions so that we take them up one by one in whatever time we have left. But Gift, over to you if you want to respond to this question from Julie, who's complimenting you on your work, but then she's also asking you to explain what are the implications of this result for programming?
All right, thank you so much, Mohammed, and thank you, Julie, for that comment and also the feedback in terms of for the presentation. Yes, we are seeing young men being more gender inequitable through our programming, and also from the engagement that we had during the dialogues, which is also influenced by the norms that are there in our communities and also the expectations. So in terms of the implication of that for programming, it does have negative implications since it's also exposing men and also leading them to more risky behaviors that can expose them and their partners to STIs, also in terms of new HIV infections. Also, in terms of them believing that a man has to be strong and also be always ready for sex. It also has an implication on our programming in terms of ensuring the equitable discussions around sex and around family planning and other SRHR services that are offered in the communities. And also, this also speaks to the issues around abuse among girls and young women in terms of them negotiating for sex, in terms of them also negotiating for the issues of condom use and also products such as PrEP. So yes, it has a more negative implication into our programming. Thank you.
Thank you, Gift. And there's one more question addressed to you about the traditional services that men are attending traditional health services, and one of the comments you made during the presentation. Would you like to share some more light on that, on all these traditional services providing a particular type of HIV care services for men?
So it's
why is there a preference for traditional?
The traditional services or traditional medicine that is available in the country and also around the rural areas, which men they try to use it to cure infections and also mostly STIs. And if there are indication or they see that the traditional medicine is not working, that's when they then present themselves to health facilities. And sometimes we find that it's already late for them to get that comprehensive assistance.
Mm-hmm. Okay. Okay, then would you also like to respond to this particular question from Didi, where she's asking, you're talking about a specific male health centers, so there's a positive reaction or recommendation to go towards male clinics. Is it emerging as a result of the study, this recommendation?
Sorry, come again.
Your question. The question is that there's a positive reaction to health services related to specific male health centers. Did that in any way come out as a recommendation of the study as well?
Yes, it did. It did. The male health clinics and corners, even within the facilities whereby it's a public health center where women and girls are there, to say if we can have a corner for men where they can just pop in and engage with the male service provider, and then they can leave.
Okay, so I think as I'll pick up other questions, I would like to ask I saw very interestingly in your presentation where you talk about 55% male who were covered in your study. In their self-assessment, they said they had a high risk to HIV, but only 25% of them actually were ever tested for HIV. So what, in your view, is the main reason for people not going to take HIV test, even though the risk perception in their self-assessment is very high?
I think one of the view is that when they are themselves at risk, or when they are exposed to these risky behaviors, most of the time you find that it's during their personal time, and also when it comes to now accessing services, the time, the inconvenience in terms of when they are being provided. Because also during these dialogues, we had service providers who were then, after the dialogues, for men who were willing to go to access STS, they were accessing STS, and also many men from our context who access STS services is through mobile services or through outreaches to their workspaces.
Okay, thank you. And let me pick up another question, which is coming from Trista, saying that it seems that many of the barriers described by men in health facilities are very similar to the ones which are encountered by key populations. So what are your thoughts about how to increase overall respect and confidentiality of services in public facilities, which could actually benefit all clients?
I believe more trainings and sensitization for health service providers would be one of the ways to increase the issues of respect and confidentiality. And also, if we can have more of the quality assurance teams in these facilities, and the feedback mechanism where clients, they can share their feedback with the facility through the community-led or other mechanisms that can be put in place in the facilities. Because by so doing, clients clients and key populations, they are able to report of any malpractice, and also if there are any facility barriers that are preventing them from accessing services. So it's more training, and also having a feedback mechanism in place, because some of the time the suggestion box are also viewed by the same people in the same facilities. Thank you.
Thank you, Gift, for your very precise and succinct answers. I really appreciate that. Participants, I invite you to raise your hands if you want to quickly ask something, or still you have a chance to write one or two questions in the question and answer box. But while you do that, let me come to Andrea. Andrea, thank you so much for your very insightful presentation, which I really appreciated and I liked very much. My question to you is, why did you think of doing this study? How the idea of doing this particular study come to your mind?
Thank you for the question. So the fact was that as part of the RCCS, there is a lot of viral load tests that are performed, and that started in around this the first round that we included in the study was when we started performing viral load tests at a high capacity. There was some start even before, but it wasn't as comprehensive. And so what we wanted to see was basically the impact of universal test and treat in basically the number of people that had unsuppressed viremia, so people that could transmit the disease. And basically the key point was, if we want really to summarize it in a couple sentences, is that before the rollout of test and treat, there were more women than men that had that were viremic. But basically, with the rollout of those treatments, and with the other thing that women are typically more better connected and follow treatment better, what we see now is that there was slowly an evening of the number of men and of women that had viremia. And so what this means is that, okay, this is very rough, but the number of people that are at risk of transmitting the disease are similar in men and women. And this makes the dynamics of transmissions and of prevention a bit different. So basically that was, we're always interested in like understanding how populations change, how risks change over time. And this is what led us to this study.
Okay, thank you. Very interesting. So participants, please feel free to raise your hands and unmute yourself and ask a question. But before they do that, Andrea, another thing, of all the places, was there any specific reason for choosing this particular community in Uganda where you did this study?
Well, yes, the Rakai Community Cohort study is a very old study. So the rounds that we considered were from the 16th to the 19th of a much longer study. So the reason why the studies took place there comes from like the very early stages of HIV. So that's one of the first regions in which HIV was confirmed to be there. And it's a study that has led to historic results that, I mean, I wasn't a PhD nor a researcher at the time. But yeah, basically there is this infrastructure, there is high HIV prevalence. Yeah, there is people that are available to answer questions and get tested, and yeah, it's very helpful and helps answering quite a lot of questions.
Okay, interesting. So would you have plans to take up a similar study in some other community in future?
Depends. Like, I think there is potential for similar things everywhere. I'm also at the time of ending my PhD, so concerning the future, it's to be discussed. But yeah, I think these things are interesting, and like it's something similar to what like the FIAs do, the population, the PHIA surveys. But I think there is something, the burden profiles that we talk about, it's something that could easily be introduced in the FIAs that's currently missing. Yeah, I would say that's. Yeah.
Okay, thank you. And we wish you good luck for your future work. Very interesting work that you have done, and congratulations.
Thank you very much.
I see one more comment or maybe question in the question and answer section. This probably is for Gift. Was there a discussion on gender distribution among staff at the health facilities? And did the health facilities have a sufficient number of health workers to serve men? Gift, want to respond to that?
Sorry, was it asking about the specific number? I'm trying to. I'm struggling with navigating to the. Sorry, the.
Yeah, the
some
question is,
questions.
what was kind of gender distribution of staff at the health facilities? Did they have sufficient number of health services workers to serve men, or was that a challenge?
No, the number of staff that were the distribution wasn't mentioned by the participants, but they were specific to say most of the time you find that in these health facilities we have female service providers.
Okay.
I'm not sure if I'm responding to
No, I
question.
think your recommendation coming from your study is very clear. It's about have a male clinics with senior staff serving and taking care of men's needs. It's coming out clearly. I don't see any more questions. I don't see any. I hope. Yeah, do you want to ask a question?
Yes, just a
Please.
quick one. Afsan, this is for Andrea. I know the data Chi code has been like monitored over a long period of time. And also I think the data that you're showing from the fishing communities really striking, showing men highlighting a higher burden in terms of possible HIV transmission in that community. If there've been no interventions happening in this community, and are these interventions failing to address this gap, or do you know if maybe anything post maybe this analysis or just before this analysis or over this time of monitoring of this code, any interventions being done targeting this issue, and why it's not making maybe a difference, or maybe the difference is happening, it's just that it's not happening at the pace that is needed? Yeah.
So yeah, thank you for the question. So I do not. There were interventions in fishing communities, and I don't think I think that they are working. And what you could see is like there is way more people that are suppressed. But the problem is just that there were so many more people with HIV to start with, and also the reasons why there is more disparities in terms of men and women is also that there is, as opposed to other places where typically, you know, in most places in the world, there would be the balance of men and women would be almost 50% in the population. In fishing communities, due to the fact that people typically go there for work or other reasons, but there is more imbalance and so there is more men than women. And so this means that men make up a larger proportion of people with HIV in these groups. So this explains the difference between men and women there. And again, yeah, I want to say that in terms of interventions, it's not like they're not working. It's just that there is the prevalence is much higher, and there's many reasons associated with that. Also, one reason why prevalence is high is also because people that have HIV have said that I've expressed that they moved to fishing communities because they know that services are better. So in a way, yeah, I think it's not correct to say that the interventions are not working. It's a more complex. It's a more complex situation. Yeah.
Okay, colleagues. So thank you very much. I'm looking at the time. We are almost at the end of the webinar. I see some colleagues have written things in the chat box. I was looking at questions and answer session, but I request Gift and Andrea to take a look at chat box also. If there's one or two areas they like to put a short comment, because I see a comment from Fiona and colleagues. You may like to respond to that. But thank you very much from my side, and I hand it back to Lysias and Vole. I think Vole would give some concluding remarks. So over to you, Vole.
Yes, thank you so much, Afsa. I think expertly done, as always. You know, colleagues, I just want to thank Gift and Andrea. I've listened with rapt attention to both their presentations. I thought they were brilliant. And, you know, what really comes to mind when I hear these presentations is how it allows us to reflect on what we do, how we plan, and how we think, on programming for men. Perhaps two reflections, one coming from actually something in the chat box that I saw from I think it was a Semita. I think it's a really poignant reminder that as we get these data and evidence from the likes of, from researchers, from Gift, from Andrea, it's an opportunity for us as well to gauge, different things. One thing would be, to look at the balance between expectation, and I saw a lot of that from Gift's presentation. So the balance between expectation and reality or feasibility, that's always really, really important. We've seen the expectations in terms of having separate male health facilities or having, men being attended to by male health workers. I think we as a community, we have that opportunity to look at those types of important information and see how we balance what is expected vis-a-vis what is practical and what is feasible. I think that's something that is really key. Now, secondly is, excuse me, from Andrea's presentation, one reflection is the need to as well be precise, right? So Andrea mentioned a lot about focusing on subpopulations, and I think this is where we're headed, anyways. So having the need to focus on subpopulations to differentiate and to make sure that as we program with fewer resources, perhaps we're able to direct those resources to where it is needed most. The third perhaps is, again, a combination of, Gift and Andrea, to just say, there is no way we're going to, get to where we need to get to, certainly as regards men, without focusing on the very big issues on gender norms and culture and structural issues. One caveat would be that as we try to respond to those issues on gender norms, we have to be careful not to unintentionally perpetuate them, if you see what I mean. Because there are ways that in responding to something, you could actually be unintentionally perpetuating those things that you're responding to. So those are just the reflections that I think come to me from those presentations. I thought they were brilliant. Good luck with your PhD, Andrea. We will be, I think we'll be looking out for you, certainly, because I think it's really exciting work that you do. And then for Gift, it was such a pleasure to listen to you, and we'll continue to follow your work for sure. Let me thank all of the participants who have listened. You stayed, for the full hour. The IT guys who have helped us to have a very smooth webinar, and certainly to the Men and HIV working group. So this is a global working group that is coordinated by WHO and UNAIDS, and we have ILO, PSI, and IAS, of course, as co-chairs. Well, I want to thank all of the co-chairs for making this happen. And onwards we go. We're going to be looking forward to the next webinar, which will be coming soon to your doorsteps. So thank you so much. And we'll be sharing all the recordings and the presentations as soon as possible. Take care, and bye-bye.
Thank you.
Thanks, Ole. Bye.